Right, so you have just received the email.
The email that completely changes everything, yeah.
Exactly. You are officially the new service line chief, or maybe division director, or medical director for the orthopedic department.
And straight away, the reality sort of hits you, doesn't it?
It really does. You're staring at your screen, and suddenly the congratulations from colleagues, I mean, people who have scrubbed in with you for years, right?
Yeah. The people who have covered your on-call shifts.
Spot on. People who have stood across the table from you during grueling revision arthroplasties. Their messages just read slightly differently now.
The banter has completely evaporated.
It's gone. There's this palpable shift in the tone. And, frankly, there's a meeting on Friday with the hospital administration to discuss your first 100 days.
Which is a terrifying prospect if you aren't prepared.
Absolutely terrifying. Because you don't fully know what they expect. And honestly, you don't fully know what you expect from yourself either.
You are terrified of changing too much, too fast, while simultaneously worrying about looking, well, entirely ineffective.
Right, because you have a team that basically expects you to solve all their systemic problems by Monday morning.
It's an impossible standard.
It is. Okay, let's unpack this properly. Stepping into a clinical leadership role without a playbook is, well, it's exactly like stepping into the operating theater to perform a complex spinal reconstruction without reviewing the cross-sectional imaging.
That imaging analogy is highly accurate, actually.
You might survive the first incision, right? But you are completely blind to the anatomy of the disaster waiting underneath.
Because what is crucial to understand here, and this is where so many fall down, is that the transition into clinical leadership is where the vast majority of exceptional, technically gifted surgeons quietly stumble.
They just hit a wall.
They do. You are moving from a paradigm where your individual technical competence dictated your success to a completely different realm.
A realm where your hands aren't doing the fixing anymore.
Exactly. Your successes now entirely depend on how you manage systems, resource scarcity, and deeply entrenched departmental behavior.
Which is a totally different skill set.
Completely different. And the frameworks we are analyzing today highlight a stark, really unforgiving reality.
But the leadership reputation you form in these first 90 days is almost impossible to reset later.
Spot on. The early missteps you make, they do not just fade away. They compound silently over your entire first year.
It's like a massive snowball effect.
It is. And most clinical leaders learn this the hard way, through deeply painful trial and error that fractures their relationships with both their peers and the hospital executive board.
Which is exactly what we're going to completely dismantle today.
Right. We are laying out a highly specific, sequenced strategy for navigating this absolutely critical window.
And that is the core mission of Deep Dive Ortho today. We are unpacking the transition from surgeon to clinical leader.
What you need to do, the specific language you need to use, and this is vital, what you must ruthlessly hold off on doing.
Because before you can even begin to implement some grand vision of orthopedic excellence,
Yes.
you actually have to survive week one.
Survive it without triggering a massive immune response from your own clinical team, yes.
Right, so we need to transition from the sheer excitement of your appointment to the strict, almost unnatural discipline required on day one.
It feels very counterintuitive.
It really does. So let us look at the very first action on the playbook, the initial communication.
Ah, the famous first email.
Yes. The frameworks dictate a precise 3-sentence message to the entire team. Just 3 sentences.
And what do those sentences need to say?
It must solely state that you are honored, that you are here to listen first, and that you will reach out to schedule time with them individually.
Which sounds incredibly simple.
Simple, yes. But I look at this and think about the sheer psychological torture of being limited to 3 sentences.
Oh, it's agonizing for a surgeon.
Right. You have likely been fuming about the inefficiencies in the trauma pathway for, I don't know, 5 years.
You've been complaining about it in the break room every single Tuesday.
Exactly. So the temptation to write a sweeping manifesto, to finally say how you're going to fix it all, must be absolutely overwhelming.
The temptation is colossal, and yielding to it is the first fatal error you can make.
Really? A fatal error just from sending an enthusiastic email?
Absolutely. Because human nature, particularly surgical nature, drives you to want to demonstrate authority and competence immediately.
You want to prove the selection committee was actually right to choose you.
Exactly. You want to show you have the answers. But you must resist the urge to issue what the operational frameworks term an anti-vision statement.
An anti-vision statement. That's a great term.
The reason we advocate for extreme, almost militant brevity here is rooted in the psychology of organizational change.
Right, because people don't like change.
They hate it. When a new clinical leader takes over, the entire department, from the most senior, heavily tenured consultant right down to the newest healthcare assistant on the ward, is scanning the horizon for one specific threat signal.
They are looking for danger.
They are. They're asking themselves, is this person going to come in swinging?
Are they going to disrupt my carefully constructed workflow?
Or challenge my clinical autonomy? Or upend the established rota before they even understand how fragile the whole system actually is?
It's a defensive posture, isn't it? They are bracing for impact.
Yes. They are essentially treating the new leader like a pathogen until proven otherwise.
That makes perfect sense. So if you send a sprawling 2-page email detailing your vision for the future,
Or worse, outlining immediate areas for quote-unquote improvement.
oh, wow, yeah. If you do that, you are validating their deepest anxieties.
You are signaling that you believe you already know what is broken.
And by implication, that means you believe you do not need their input at all.
Exactly. A 3-sentence email, on the other hand, is a deliberate, highly calculated de-escalation tactic.
It neutralizes the immediate threat response.
It actively lowers the collective blood pressure of the department. By stating you are simply honored and your sole priority is to listen, you demonstrate restraint.
Which, to a highly educated clinical team, is the most powerful early indicator of a sophisticated, self-aware leader.
Right. It's a fascinating pivot from how we usually operate clinically.
Because surgeons are inherently wired to act.
We are. If there is a fracture, we fix it.
If there is a hemorrhage, we clamp it.
Yeah.
We are conditioned to associate immediate intervention with competence.
But this playbook is advising a complete, deliberate pause.
And this leads directly into how you utilize your calendar as a political signal in that very first week.
The calendar is your biggest tool here.
The strategy insists you schedule 20 to 30-minute one-on-ones with every single member of the team.
Every single one.
And I really want to emphasize this for the listener. The frameworks are explicit that this means every theater nurse, every junior doctor, every administrator, and every ward coordinator.
Not just the senior consultants.
Right, not just the people who supported your application for the job.
The logistical burden of scheduling 60 or 70 individual meetings is immense. I mean, a nightmare.
It sounds like it would take weeks just to organize.
It does, but the return on investment is unmatched by any other early action you could possibly take.
How so?
Because the physical act of populating your calendar with these meetings is a profound political signal, and it happens before a single word is even spoken.
It's about optics, then.
It's deeper than optics. In traditional medical hierarchies, information, influence, and access are typically funneled through a very narrow bottleneck of senior individuals.
Right, the old boys club or the senior management group.
Exactly. By bypassing that bottleneck entirely and deliberately placing a junior theater nurse or a pre-assessment clerk on your calendar for an uninterrupted 30 minutes.
You are sending an undeniable message about your methodology.
You are stating that you value operational reality, the actual truth of what happens on the floor, over hierarchical status.
They will undoubtedly talk to each other about it, won't they?
Oh, the hospital grapevine is incredibly fast.
The registrar will mention to the senior consultant that they just had a 30-minute sit-down with the new chief.
And suddenly, the narrative in the corridor shifts from anxiety to curiosity.
You are establishing a reputation for being exceptionally thorough.
Spot on. But it is not just your own clinical team you have to manage in week 1.
No, you are suddenly thrust into the administrative matrix as well.
You have to schedule time upstream with your medical director, the chief operating officer, and the administrators who actually hold the purse strings.
What is the objective here, though? Because surely week 1 is too early to start demanding capital for a new robotic suite.
The objective is absolutely not to make demands or to present a budget wish list.
Because if you do that, you just look greedy.
Worse than greedy. You immediately brand yourself as politically naive.
So what should you be doing in those administrative meetings?
The objective is cartography. You are mapping the political and financial fault lines of the hospital.
That's a brilliant way to phrase it.
When you sit down with the hospital administration, you must ask them directly what keeps them awake at night regarding the orthopedic service line.
You want to know their nightmares.
You are trying to understand their structural pressures. Are they under massive scrutiny from the national regulator regarding elective waiting lists?
Or are they bleeding capital through exorbitant agency nursing spend?
Right. Or are they terrified about the theater utilization rates dropping below 80%? You need to uncover the specific metrics they are being judged on.
Because they have bosses too.
Exactly. Because if you do not understand their anxieties in week 1, you will inevitably step on a political landmine in week 4.
By proposing a clinical initiative that inadvertently worsens their primary financial metric.
Yes. And then they will shut you down immediately.
Okay, I have to stop you there, though. Because the next point in the framework, the zero decision rule for the first week, it sounds magnificent in a management textbook.
But you're wondering how it works in reality.
Exactly. Let us look at the reality of a busy orthopedic trauma unit.
Go on.
You are instructed to make absolutely no decisions in the first week, not even the easy ones.
Sure.
But suppose it is a Friday afternoon. The trauma list is completely collapsing. You have 2 major pelvic fractures incoming from a road traffic accident, and the bed manager is flat out refusing to open the escalation ward.
A classic scenario.
If you just sit in your office, quote-unquote, absorbing data, instead of picking up the phone and demanding those beds,
You look incompetent.
you are not a leader. You are a spectator.
Yeah.
How does this rule survive contact with actual clinical chaos? How is inaction not simply negligence?
It's a vital distinction to make. We must differentiate between clinical triage and systemic policy changes.
Okay, explain that.
The zero decision rule does not mean you abandon your duty of care. It doesn't mean you stop functioning as a senior clinician during a crisis.
So you still fight for the beds.
Absolutely.
Right.
If there is an immediate patient safety issue, you intervene. You pick up the phone. You manage the trauma list.
So what does the rule actually prohibit then?
What the rule strictly prohibits are structural, operational, or administrative decisions.
I see.
The fear of looking weak or indecisive drives new leaders into a trap of premature operational action. They want the dopamine hit of productivity.
They want to fix a system, not just a patient.
Exactly. Let us say you make a seemingly obvious operational change to the theater turnaround protocol on day 3.
Just to demonstrate that there's a new sheriff in town.
Right. What you do not know yet is the complex historical web of compromises, staffing shortages, and union agreements that led to the existing protocol.
Even if it is a flawed protocol.
Even if it's terribly flawed. By changing it blindly, you might inadvertently alienate your lead anesthetist.
Or trigger a mass grievance from the nursing staff.
Yes, because you didn't understand why the system was built that way in the first place.
So essentially, you are treating the department's culture and operations like a complex, multifragmentary fracture.
That is a brilliant analogy.
You do not just pull on the limb and hope it aligns, right? You have to understand the exact mechanism of injury first.
Otherwise, you're just going to cause further soft tissue damage and compromise the vascular supply.
The mechanism is everything.
And the cost of a bad first operational decision is exponentially higher than the cost of waiting another week to act.
Because you lose trust.
A bad early decision signals to the entire multidisciplinary team that you are arrogant, impulsive, and totally disconnected from the realities of the floor.
It incinerates the foundational trust you need to operate.
It does. Waiting, observing, and absorbing does not make you look weak. It makes you look measured, analytical, and safe.
And the team will always respect a leader who takes the time to thoroughly understand the pathology before prescribing the treatment.
Always.
Okay, so week 1 establishes that you are not going to tear the place down.
You've survived the initial threat phase.
You have sent your 3 sentences. You have flooded your calendar with 30-minute meetings. You have mapped the administrative anxieties.
And you have ruthlessly suppressed your surgical urge to intervene in the operational workflows.
It sounds exhausting already. Now we move into the actual execution of those meetings.
The listening tour.
Right. How do you utilize those 30-minute slots? The framework dictates a structured data gathering mission over the next 6 weeks.
This is the process by which you earn the political capital to actually act later.
The word structured seems to be the linchpin of this entire phase.
It is entirely the linchpin. This is not a casual chat over coffee to get to know someone's hobbies or where they went on holiday.
Right, you're not there to be their best mate.
Every single one-on-one must follow a loose but highly consistent analytical structure.
Why so rigid?
Because if you ask vastly different questions to the ward sister than you do to the senior consultant, you cannot accurately compare the resulting data.
It becomes anecdotal instead of analytical.
Exactly. The framework suggests a highly specific set of diagnostic questions.
Let's go through them.
First, what is working well right now? Second, what is consistently frustrating your daily workflow?
The pain points.
Yes. Third, what do you wish someone would change immediately? Fourth, What are you personally proud of in this department?
And the last one.
And finally, what specific resources would help you perform your role better?
I really want to focus on that specific question. What are you proud of?
It's a powerful one.
It is. Because we are so heavily conditioned in healthcare to focus on deficits, aren't we?
Constantly.
I mean, M&M conferences, root cause analyses, incident reporting. Our entire mental model is built around identifying what is broken.
Or what the complication was, or why the waiting list has breached the target.
Right. So asking people what they're actually proud of seems like a highly strategic psychological maneuver to break that negative conditioning.
It is incredibly strategic. And it serves two vital functions for the new leader.
What is the first one?
Firstly, when you ask someone what they are proud of, you are identifying the departmental assets that must be protected at all costs during your future reorganization.
Oh, I see. Finding the load-bearing walls.
Exactly. Sometimes a department has a highly dysfunctional administrative pathway, but the culture of informal teaching and camaraderie amongst the registrars is absolutely exceptional.
So if your future efficiency mandates inadvertently destroy that teaching culture.
You have failed as a leader. You need to know where the cultural assets are before you start renovating.
And the second function of that question.
Secondly, asking this fundamentally changes the emotional tenor of the meeting.
It stops it from just being a moan fest.
Right. It moves the conversation away from being a pure, toxic grievance session.
Which is draining for everyone.
It validates the individual's hard work and acknowledges that despite the systemic brokenness, they have been holding the line prior to your arrival.
That's brilliant. Now, during these meetings, the playbook emphasizes the strict discipline of note-taking.
Real physical notes.
Yes, real physical notes for yourself, completely separate from any official human resources file.
This is where a lot of doctors push back.
I can imagine a lot of highly intelligent clinicians might balk at this. They might think, well, I diagnose complex multi-system trauma every day.
Surely I can remember the gist of a conversation with the physiotherapy lead.
Exactly. Why do I need to write down everything a scrub nurse tells me?
Because the human brain is exceptionally poor at retaining nuanced, unstructured, qualitative data over a 6-week period.
No matter how intelligent the clinician is.
No matter how brilliant you are in theater. If you conduct 60 interviews, by week 4, the individual conversations will blur into an indistinguishable amorphous mass of general dissatisfaction.
Just a cloud of complaints.
True operational patterns only emerge across dozens of data points, and memory is highly fallible.
It's susceptible to recency bias, isn't it?
Highly susceptible. If you do not take notes, you will only remember the loudest, most aggressive complaint from the most intimidating consultant you spoke to yesterday.
While completely forgetting the quiet, systemic issue raised by 6 different scrub nurses 3 weeks ago.
Exactly. By taking physical notes and the frameworks, highly recommend pen and paper over a laptop here.
Why pen and paper?
Because a screen creates a physical, defensive barrier between you and the speaker.
It looks like you're checking emails.
It does. With pen and paper, you are building a searchable, objective database of the department's psychology and operational friction, whilst remaining physically open.
But as you are taking these notes and really listening to these profound frustrations, there is a massive trap waiting for the new leader.
The fix-it reflex.
Yes. Let us introduce a hypothetical scenario to ground this for the listener.
Okay.
You are sitting across from Dr. Harrison. He is one of your highest-producing spine surgeons.
A very important person to keep happy.
Right. And he looks you in the eye and describes with immense frustration how the lack of a specific 10,000-pound orthopedic microscope is delaying his lists and compromising patient care.
He makes a very compelling clinical case.
It is so easy in that moment to validate him, to say, I completely understand that is unacceptable. I will get that sorted for you.
It feels like the right thing to do.
It feels like you are building an alliance in real time. You want to fix it. Why is this fix-it reflex so universally dangerous?
The fix-it reflex is the leadership equivalent of prescribing broad-spectrum antibiotics for a viral upper respiratory tract infection.
You just want to do something.
You do it because the patient is sitting in your clinic demanding action, and it feels deeply uncomfortable to send them away empty-handed.
As physicians, our neurochemistry actually rewards us for providing immediate solutions to suffering or frustration.
We get a dopamine hit from solving the problem. But making a promise in the room during a listening tour is a catastrophic, unforced error.
Because you don't actually know if you can deliver it.
You are operating with severely asymmetrical information. You only have Dr. Harrison's perspective.
You do not yet know the hospital's capital budget constraints.
You do not know the administrative pushback regarding that specific supplier.
And you do not know if procuring that microscope means canceling the purchase of 3 new anesthetic machines that the rest of the department desperately needs.
You are promising to perform a procedure without knowing if you have the blood products available to support it.
That's exactly it. You're flying blind.
Precisely. And the psychological fallout when you fail to deliver is severe.
It breaks the trust immediately.
An unkept promise poisons the working relationship significantly faster than the original structural problem ever did.
How do you mean?
Well, if Dr. Harrison does not have his microscope initially, he is annoyed at the abstract concept of hospital administration.
He's mad at the system.
But if you look him in the eye, promise to fix it, and then fail because the budget committee blocks you.
He's now annoyed at you personally.
Exactly. You have transferred the institutional failure onto your own shoulders.
Wow. You've essentially volunteered to be the bad guy.
You have. Your credibility is the absolute only currency you possess as a new clinical leader.
And making promises you cannot mathematically guarantee will bankrupt that currency in the first month.
So you take the notes, you nod empathetically, you validate their frustration, but you promise absolutely nothing beyond investigating the issue.
That takes immense discipline.
It really does.
And while you are listening, the strategy outlines the concept of diagnostic listening.
Yes, this is a crucial skill.
You have to differentiate between universal complaints, where 12 people independently cite the exact same issue, and individual grievances.
Which can sound very similar in the room.
Right. So how do you practically separate the noise from the signal when everyone believes their issue is the most critical?
This requires severe analytical rigor. An individual grievance is very often presented with incredibly high emotional intensity.
Lots of table banging.
Exactly. A senior surgeon might bang the table and declare that the lack of a specific brand of retractor is destroying the entire department's efficiency.
And risking patient safety, they always throw that in.
Always. The volume is very high. But if you consult your meticulously kept notes and realize that in 50 other interviews, not a single other person mentioned that retractor,
you have successfully diagnosed a personal preference masquerading as a systemic crisis.
Spot on. Conversely, a universal complaint might be delivered very quietly.
Almost with a sense of resignation, right?
Yes. 12 different nurses might casually mention, almost in passing, that the handover process between the day and night shift is chaotic and dangerous.
That quiet, consistent repetition across different professional disciplines is your true signal.
That is the systemic pathology you must prioritize.
And the playbook goes even deeper into diagnostic listening, doesn't it?
It does. It tells us to listen for what is not said.
The topics that are glaringly avoided.
The decisions that no one seems willing to take credit for.
The colleagues who are described very, very carefully. What are we looking for in the shadows there?
We are mapping the unsaid in medical hierarchies.
The unsaid.
The unsaid is the dark matter of hospital politics. You cannot see it directly, but you can observe its heavy gravitational pull on everything else in the department.
Give me an example of that.
If you ask about how the trauma list is allocated on weekends, and suddenly the normally talkative registrar becomes very brief, breaks eye contact, and looks at the floor.
You have found a major cultural pressure point.
Exactly. If a particular senior consultant is only ever described by the nursing staff with heavily qualified adjectives.
Like, well, Mr. Davies is very traditional, but a brilliant surgeon.
Yes. When you hear that, you are hearing the echo of fear or a systemic workaround for toxic behavior.
They are telling you without telling you.
True issues, the deeply entrenched behavioral problems, will rarely surface in your first meeting.
They don't trust you enough yet.
Right. They only begin to crystallize on the second or third conversation, once the individual realizes you are actually trustworthy and not just an administrative spy.
So at the end of these exhaustive 6 weeks, you have a notebook full of nuanced diagnostic data.
A goldmine of data.
You've survived the listening tour without making toxic promises. Now, the frameworks insist you must distill this into an output document.
A clear, written strategy.
Comprising 3 specific things, right? 2 to 3 real issues identified by the team, 2 to 3 assets the team wants protected, and a stark, unvarnished assessment of the actual political reality you are operating within.
That's the formula.
But why formalize it in writing? Why not just hold the synthesis in your mind and start acting?
Because the act of writing forces absolute clarity. It forces you to strip away your own pre-existing emotions and biases.
It stops you from just executing your own original agenda.
Exactly. When you distill 60 conversations down and commit the 2 or 3 primary systemic issues to paper, you are officially creating your leadership mandate.
And crucially, because these specific issues were organically identified by the team during your tour.
It is not your mandate imposed upon them from above. It is their mandate reflected back to them.
That is so powerful.
When you eventually act, you can stand up in the departmental meeting and say, I have spoken to 60 of you. I have reviewed all the notes.
The overwhelming consensus from this entire team is that we must urgently address the theater utilization rates.
And the disjointed preoperative assessment pathway, exactly.
That provides you with immense political cover and immediate department-wide alignment.
You are just executing their will.
Okay, so we have built the foundation. We understand the landscape, we know where the landmines are, and we know what the team actually cares about.
Now we reach the pivot point.
Around weeks 6 to 8, the moratorium on action is officially lifted.
It is time to make the first move.
This is what the playbook calls the calibration moment.
A very dangerous moment.
How do you go about selecting this first issue? Because it sounds like a high-stakes Goldilocks scenario. You need to pick an issue that isn't too hot to cause an explosion, but not too cold that no one notices you actually did anything.
It is precisely a Goldilocks scenario, and it is a highly delicate maneuver.
So what are the extremes we need to avoid?
You must avoid the extremes at all costs. Do not attempt to tackle the most systemic, deeply rooted, politically radioactive issue in the hospital as your first act.
Like rewriting the entire consultant on-call rota.
Or overhauling the financial incentive structure in week 7.
Right.
If you try that, you will face massive coordinated resistance.
And you will likely fail.
You will cripple your tenure before it even begins. You do not have the political capital for that yet.
What about the other extreme?
Conversely, do not pick something trivial like changing the brand of coffee in the break room or redesigning the departmental letterhead.
If your first decision is trivial, the clinical team will immediately assume your entire leadership tenure will be trivial and superficial.
They will write you off as a lightweight.
So what does a medium-sized, perfectly calibrated decision actually look like in a clinical setting? Give us a concrete example.
It needs to be a decision that is meaningful to the daily workflow, but not catastrophic if it requires later adjustment.
Okay.
For example, standardizing the protocol for ordering non-stock orthopedic implants for elective arthroplasty cases.
That's a good one. Because currently, let's say every surgeon orders whatever they want, whenever they want.
Causing massive delays, inventory chaos, and administrative friction.
It is a process that frustrates people, it causes delays on the day of surgery, and it has a measurable financial implication.
Exactly. It is visible enough that the theater staff, the inventory managers, and the surgeons will notice it has been handled.
But small enough that if your new protocol needs tweaking in a month because you missed a nuance regarding complex revisions, it will not permanently define your reputation as a failure.
Right. It's adjustable.
And the playbook stresses that the way this decision is made is actually more important than the decision itself.
The method is the message.
It is setting the paradigm. If you want to be known as a highly consultative leader, you must consult heavily on this specific implant decision.
If you want to be known for decisive clinical prioritization, you must be highly decisive here.
Why is the methodology of this first decision so critical to get right?
Because it casts a very long shadow. The team is not just watching what you decide, they are forensically examining how you decide.
They are looking to decode the algorithm of your leadership.
If you make this first decision about implants behind closed doors, without speaking to the lead scrub nurse or the inventory manager,
the team will immediately conclude that you are an autocratic leader who does not value multidisciplinary input.
even if the decision itself is brilliant and saves the hospital a fortune, the method will alienate the staff.
So your first decision is an active public demonstration of your leadership methodology.
You must deliberately, almost theatrically, perform the behaviors you wish to be held to for the rest of your term.
You are literally teaching them how to interact with you going forward.
Yes.
And a massive part of that interaction is transparent communication.
Which is where many leaders get scared.
The guidance states you must communicate the decision directly, ideally in person. Crucially, you must explain the reasoning and openly acknowledge any dissenting views.
Do not pretend the decision was unanimous if it was not.
No, I have to push back here.
Go ahead.
Acknowledging dissent openly feels incredibly vulnerable. Isn't that just putting blood in the water for the sharks? Why not just present a united front and say the leadership team has agreed to move forward this way?
Because clinical teams are highly intelligent, highly observant, and they possess incredibly robust informal communication networks.
The grapevine again.
If there was severe disagreement about the implant protocol behind the scenes, they already know about it.
The registrars know, the nurses know, the ward clerks know.
Everyone knows. If you stand up in a meeting and pretend the decision was unanimous, you instantly destroy your intellectual honesty.
You prove to the entire department that you are willing to spin the truth or outright lie to make your life easier and avoid conflict.
You lose your credibility instantly because they can see the glaring gap between your words and the reality they experience.
Okay, that makes sense. But what is the alternative?
Consider the alternative. You stand up and say, we are moving to this new standardized implant protocol. No, I know Mr. Smith strongly feels we should have gone with a different supplier.
You name it directly.
Yes. And you say his concerns about the specific trauma applications of this new system are entirely valid and were heard.
Validating him in public.
However, based on the overall budget constraints handed down by the executive board and the superior reliability of this new supply chain, I have decided we must proceed this way.
What happens then?
You have publicly validated Mr. Smith's intelligence and clinical acumen. You have taken absolute ownership of the final decision, and you have demonstrated that dissent is not punished.
But it does not paralyze the department either.
Exactly. This intellectual honesty builds a massive reserve of trust. It is armor, not vulnerability.
And that trust will carry you through the much harder, more controversial decisions you will face in year 2.
It is about proving that you can hold opposing realities in your head without panicking.
Now, speaking of opposing realities, we have to talk about the absolute minefield that is the clinical administrative divide.
Ah, the great divide.
Because your decisions do not just impact the surgeons and the nurses. They intersect directly with hospital administration.
Navigating this dual-facing reality is where we see so many brilliant, highly capable clinicians suddenly hit a brick wall.
They're exceptional surgeons, but terrible medical directors.
What is the pathology here? What actually goes wrong?
What goes wrong is that physician leaders, lacking formal training in organizational dynamics, usually fall into one of 2 fatal traps.
Let's break those down. The first trap.
The first trap is becoming the administration's voice to the clinicians.
You get captured by the executive board.
Exactly. You start parroting the language of the finance director. You go to the clinical team and say, we must cut costs. The board is demanding better margins. We need to increase throughput.
When you do that, the clinical team immediately views you as a traitor.
You are seen as having gone over to the dark side.
You lose all clinical credibility, and once you lose that, you lose your ability to influence the clinical team's behavior.
You become just another suit to them, even if you are still wearing scrubs.
And the second trap.
The second trap is the exact opposite, and it is often driven by a misplaced sense of loyalty, becoming the clinician's voice against the administration.
Yes. You become their fierce, unyielding advocate. You storm into the executive management meetings and bang your fist on the table, demanding unlimited resources for your department.
Refusing to acknowledge the hospital's crippling financial realities.
And threatening to resign if you do not get your way.
I've seen that happen.
We all have. When you do that, administration writes you off as naive, uncooperative, and a systemic danger to the broader organization's survival.
You lose your effectiveness. You are quietly excluded from the real strategic meetings, and your access to capital and resources completely dries up.
Both paths are complete dead ends.
It sounds like an impossible choice between being despised by your clinical peers or being entirely ignored by your executive bosses.
It does feel that way initially.
So what is the sustainable path? The framework calls it the translator model. What does that actually mean in the trenches?
It means you must fundamentally alter your communication strategy depending on which room you are standing in. You must become a bilingual leader.
Bilingual in finance and medicine.
You have to understand that clinicians and administrators speak entirely different languages based on entirely different incentive structures.
Okay.
When you are speaking to the clinicians, you must explain administration's concerns in a way that makes logical sense to them without ever abandoning your core clinical perspective.
I need a highly concrete example of this. How do you translate a pure administrative financial concern for a clinical audience that only really cares about patient outcomes?
Let us take a classic friction point locum spend.
Oh, everyone fights about locum spend.
The hospital administration mandates a strict 10% reduction in locum and agency nursing spend across the orthopedic directorate.
If you just pass that mandate down verbatim, Admin says we have to cut locums to save money. The clinicians will immediately revolt.
They will cite patient safety, they will cite burnout, and they will fight you tooth and nail.
So how does the translator handle it?
As a translator, you take that administrative financial mandate and actively reframe it around clinical quality and team cohesion.
You change the narrative.
You say to your surgical team, the board needs to reduce locum spend, yes. But from our clinical perspective, this high reliance on temporary agency staff is actually degrading our continuity of care.
It is frustrating. Our permanent nursing staff who have to constantly orient new people who don't know our trauma trace.
Precisely. You say, we need to restructure our rota and reduce locum use not just to satisfy the finance director, but to build a more stable, cohesive, expert surgical team.
That provides vastly better patient outcomes and a less stressful working environment for all of us.
You have successfully translated a dry financial metric into a compelling clinical quality argument.
That is exceptional. You are aligning the financial necessity with their core clinical values.
You are showing them how solving the admin problem actually solves their clinical problem.
But the translator model must work both ways, right?
It absolutely must.
We also have to explain clinical realities to the administration. How do you do that without sounding like you are just an entitled surgeon demanding more money and toys?
By speaking their specific dialect data, risk metrics, throughput, and budget impacts.
They don't care about the emotions.
Administrators, generally speaking, do not respond to emotional appeals about how tired the registrars are or how frustrating a piece of equipment is.
They manage risk and capital.
If you need a new piece of orthopedic imaging equipment, do not go into the boardroom and tell them the current one is annoying to use or that the image resolution isn't optimal for your personal preference.
That won't get funded.
Never. Translate the clinical need into administrative risk. You present a rigorous business case.
What does that sound like?
You say, the current imaging equipment is failing intermittently. This delays our theater turnaround time by an average of 14 minutes per case.
Over a month, that equates to 3 canceled elective operations.
That represents a lost revenue of X amount, alongside the increased clinical risk of delayed treatment, which exposes the trust to potential litigation.
Investing in the new equipment will pay for itself in recovered theater time within 8 months.
You are converting a clinical workflow frustration into an undeniable mathematical operational metric.
It's brilliant. But if we connect this to the broader reality of the job, it sounds like you are choosing to be universally uncomfortable.
You are.
You are constantly the bearer of uncomfortable context to both sides. The clinicians think you care too much about the budget, and the administrators think you are too protective of the clinical workflow.
It's a lonely place to be.
How do you prevent yourself from feeling totally isolated, misunderstood, and eventually burned out by this constant grinding friction?
You must fundamentally redefine your psychological relationship with discomfort.
You just have to get used to it.
The framework explicitly states that you must accept early on that you will be uncomfortable in both rooms.
That discomfort is not a sign that you are failing at leadership.
No, that discomfort is the fundamental nature of the job. You are the human friction point between infinite clinical need and finite hospital resources.
And leaders who desperately avoid this mutual discomfort, who try to be universally loved and understood by one side,
they end up captured by that side and entirely irrelevant to the other.
Embracing the discomfort of the translator role, accepting that you will never be fully one of the gang again, is the only way to maintain integrity and drive effectiveness across the entire organization.
It is a harsh truth, but a necessary one.
This raises a massive question about stamina and self-preservation, because even if you master the listening tour, and even if you become the perfect bilingual translator, the playbook outlines a series of subtle operational and interpersonal errors that can silently erode your foundation throughout that critical first year.
These are the traps that catch very smart people.
Let us look at the first one, the clinical load trap.
This is a huge one for surgeons.
We define our entire identity by our time in theater. The thought of stepping away from the operating table is terrifying. What is the trap here?
The trap is the profound, almost delusional underestimation of the cognitive time leadership actually requires.
We think we can just do it on the side.
Many new medical directors or clinical leads attempt to maintain their full historical clinical load, their clinics, their theater lists, their on-call commitments,
while simply bolting the immense responsibilities of leadership onto their evenings, weekends, and lunch breaks.
Which is a guaranteed recipe for rapid, catastrophic burnout.
Real leadership requires real time.
The strategic planning, the complex one-on-ones, the exhausting administrative meetings, the delicate conflict resolution. It requires real, focused, high-level cognitive time during the working day.
But giving up clinical time often means a direct, substantial hit to income, especially in private practice models or certain clinical excellence award structures.
It does.
And there's a massive ego component, too. You do not want to be seen by your peers as stepping back from the coalface or de-skilling.
It is a deeply painful professional and financial trade-off, but it must be made deliberately and negotiated upfront.
If you do not carve out dedicated, protected time for leadership, the leadership work gets done at night when you are cognitively depleted.
It gets done poorly. You start missing the subtle political nuances in emails, your communication becomes terse and reactive, and you begin to deeply resent the very leadership role you worked so hard to achieve.
You must negotiate protected time with administration, even if it means a temporary drop in income or handing over some of your elective lists.
You simply cannot do two full-time jobs simultaneously and succeed at either. One of them will inevitably fail, and it is usually the leadership role that suffers first.
The next mistake is fascinating from a sociological perspective. The false ally trap.
The eager greeters.
Yes. When you get a new title, suddenly people you barely spoke to for the last 5 years are offering to show you the ropes, agreeing enthusiastically with all your ideas, and positioning themselves very close to you.
It flatters the ego.
The playbook warns against getting too close, too fast to the wrong people. Why is this so dangerous? Isn't it good to have enthusiastic supporters early on?
Not necessarily, because early, overly eager allies are very often positioning themselves for their own benefit, not yours.
In corporate and clinical psychology, this is known as the eager greeter phenomenon.
The people who rush to surround a new leader, who offer unsolicited advice about who to trust and who to avoid, almost always have a hidden agenda.
They might be trying to secure disproportionate resources for their specific subspecialty.
Or they might be trying to isolate you from their historical rivals within the department.
If you commit to these early allies, if you take their word as gospel, you alienate the quieter, perhaps much more competent and objective members of the department who are hanging back.
Who are just watching to see if you are a good judge of character.
So how do you handle the eager greeters without making enemies of them? You don't want to push away someone who might genuinely just be trying to help.
You employ strategic, polite neutrality. You stay friendly. You listen to their input. You thank them for their perspective. But you make absolutely zero commitments to their specific agendas.
The framework advises taking a full 6 months to observe the true social dynamics of the department.
You need to see how people actually behave under pressure, how they treat the junior staff when they think no one is watching, and who genuinely holds the respect of their peers before you decide who your trusted inner circle will be.
That requires immense emotional intelligence and patience.
It's one of the hardest things to do.
Now, we arrive at the mistake that I guarantee resonates with absolutely everyone listening.
The prickly colleague trap.
Every single clinical department has one. The brilliant, technically gifted, but prickly, destabilizing, often, frankly, toxic colleague whom everyone else has simply worked around for years.
The nurses walk on eggshells, the registrars try to avoid their lists.
But they bring in huge volume or handle the most complex cases. The instinct, especially in your first 90 days when you're just trying to keep the peace and survive, is to let sleeping dogs lie.
It's the path of least resistance.
Why is avoiding them such a massive, loud signal to the rest of the team?
Let us use a clinical metaphor. The brilliant but toxic colleague is an asymptomatic but rapidly expanding aortic aneurysm.
Wow. Ignoring it is highly comfortable right now, but mathematically, it guarantees a catastrophic rupture later.
This goes to the absolute core of your leadership courage. The reason everyone has worked around this individual for years is because confronting them is exceptionally difficult.
Legally fraught and emotionally exhausting.
The entire department is intimately aware of this person's unacceptable behavior. When you step into the leadership role, the multidisciplinary team is watching you with a single burning question in mind.
Are you going to be just another weak leader who tolerates the dysfunction because it is easier, or are you going to finally possess the spine to address it?
Precisely. If you ignore it, you are not just keeping the peace. You are basically endorsing the behavior and proving that the rules only apply to the junior staff.
Worse than endorsing it, you are proving your own fundamental weakness.
If you avoid the difficult conversation because it is hard, your authority evaporates instantly. You must have the difficult conversation early.
This does not mean you march in and fire them in week 2, which you likely don't have the power to do anyway. But it means you sit down with them behind closed doors and explicitly define the boundaries of acceptable professional conduct moving forward.
You must document it. You must demonstrate to the broader team that you see the problem, you acknowledge the dysfunction, and that you possess the fortitude to manage it.
Whatever disciplinary or rehabilitative consequence you eventually decide is the right maneuver, the team needs to see that you did not shy away from the friction.
You must prove that clinical brilliance is not a free pass for cultural toxicity.
Finally, the last trap in the playbook is the competence trap. This brings us full circle.
It's the ultimate reality check.
Forgetting that you are, at your core, still a clinician. With all this focus on strategic frameworks, bilingual translation, emotional intelligence, and conflict resolution, how important is your actual surgical skill to your leadership authority?
Can you just be a pure manager now?
Right. Can you just hang up the scrubs?
Your clinical skill is the absolute bedrock of your authority. Whatever clinical work you choose to retain, even if it is only a 20% commitment, perhaps one clinic and one elective list a week, it must be executed to an exceptionally high standard.
In a highly specialized clinical environment like orthopedics, a leader's credibility is intrinsically and inextricably tied to being seen as a competent, working clinician who still understands the physical reality of the job.
If you start rushing your clinics, if your theater lists become chaotic and poorly managed, or if you lose your technical edge because you were distracted by administrative duties, the clinical team will lose respect for you at a terrifying speed.
The day you stop seeming like a highly competent working clinician is the day a slow, irreversible erosion of your leadership authority begins.
Precisely. They will stop listening to your strategic advice, they will reject your operational changes, and they will ignore your attempts at translation.
Because they will believe you have lost touch with the visceral reality of patient care.
You must protect your clinical excellence fiercely. It is not just your day job. It is the source code of your leadership legitimacy.
This has been an incredibly dense, nuanced, and valuable exploration of a transition that, frankly, medical school never prepares us for.
They teach us how to operate, not how to lead.
To summarize this immense playbook for the listener, the first 90 days of a leadership role are not about proving you are a visionary, transformative leader yet.
They are about survival and avoiding the types of predictable, compounding mistakes that can cripple your tenure before you even understand the landscape.
You must listen first with immense structured discipline. You must decide deliberately and transparently when the time comes.
You must act as an honest translator between the often conflicting realities of the clinical floor and the executive boardroom.
And through it all, you must protect your clinical credibility at all costs. By month 4, if you have executed this restraint and discipline, you will have earned the foundational trust and political capital required to start driving real systemic change.
The overarching theme here is restraint, analytical diagnosis, and deliberate methodology.
Clinical leadership is not about immediate action or indulging the surgical reflex to intervene. It is about strategic diagnosis, followed by a highly calibrated intervention.
Spot on.
And that brings us to a final provocative thought for you to mull over as you head into your clinic or scrub into theater today.
Think about the broader culture of the hospital or the specific department you currently work in.
Look at the persistent, baffling dysfunctions, the entrenched silos, or conversely, the areas of exceptional collaboration and efficiency.
How much of your department's current reality, the good, the bad, and the toxic, is simply the long-standing, reverberating echo of the first 90 days of the person who is currently leading it?
It is a deeply sobering thought about the massive legacy of beginnings. If you are stepping into clinical leadership this year, do yourself a favor. Draft your 3-sentence first-week message tonight before day 1 even begins.
Keep it brief, keep it humble, keep your powder dry.
And if you found this deep dive valuable, please take a moment to rate and share Deep Dive Ortho with a colleague who is preparing to step into a leadership role of their own.